So we're going to switch gears now, and we're really excited for the next session. We're going to have Mark Smolinski deliver a TED-style talk on using innovative technology-backed solutions to improve disease prevention, response, and control around the world. This will be followed by a panel conversation with nonprofit leaders who are fostering an ecosystem of technology for good in India. Mark Smolinski brings 25 years of experience in applying innovative solutions to improve disease prevention, response, and control across the globe. Mark is leading a team that co-creates tools for early detection, advance warning, and prevention of pandemic threats. Since 2009, Mark has served as the Chief Medical Officer and Director of Global Health at the Skoll Global Threats Fund, where he developed the Ending Pandemics in Our Lifetime initiative in 2012. With that, I'd like to invite Mark on stage.
Well, good afternoon, everyone, and thank you for the privilege of speaking to you today. I know the topic was about technology for development, so I just played around with the words a little bit and using technology for all the right reasons to end pandemics. We hope we can inspire you with the work that we're doing and see how it applies to the systems changes that we've been talking about early. So just a word about the problem. Since I only have 10 minutes, I want to talk about the good news and the solutions. But the issue about emerging diseases and pandemics, unlike what we thought many years ago when infectious diseases were on the out and everybody switched to chronic diseases, we now know that unfortunately infectious diseases are on the rise, and we've had about 3 to 5 new diseases detected every year somewhere on the planet for the last 3 or 4 decades. And not only are the numbers increasing, but they're increasing in density in particular areas of the world. Certainly global travel and trade, where we can transport across the globe as a human, maybe incubating a disease before we're even symptomatic, adds to the complexity of dealing with pandemics. And then lastly, the world's not prepared for a pandemic. The most recent analysis, the Global Health Security Index that just came out a few weeks ago, which looked at publicly available data in all countries across the globe, and not one single country actually meets the standards of being prepared for a pandemic, including the one we're sitting in right now. The other complex part of the problem, and I was enjoying the conversation about systems change, we have a big systems change we need in finding outbreaks faster, and that's one that we refer to as One Health. So traditionally, we wait for a human disease to appear, we do everything we can to find all the cases, control the epidemic, and then we move on. But the reality, and this is a hotspot map, that is just looking at where diseases are emerging. So once a disease emerges, of course, for many diseases, the entire world is at risk. So we know that 3 out of every 4 diseases jumps directly from an animal to human, and these are the big pandemic threats that we worry about. Certainly we're all living with the biggest pandemic of HIV, which jumps, we know, from primates to humans, but we've seen Ebola and Zika, and certainly the annual threat of flu, which we worry about becoming the next pandemic flu. These are all diseases that jump from animals to humans. And so this hotspot map really represents the zoonotic risk. And this, for us, is where we want to focus our attention, because we believe we need more eyes and ears across this part of the hotspot zone so that we can find these outbreaks as really the rate-limiting step in us being able to respond. So our solution is really focused on the One Health approach. But again, we focus entirely on surveillance. We work together with an alliance of 10 other foundations that cover the entire spectrum of everything that needs to be done in pandemics. And this was a result of the Ebola 2014 that really brought this community together. But we work up front to focus entirely on surveillance because we believe that this is really an underfunded step. So because we're looking at early detection, everyone's interested in big data. And I certainly had the fortune of helping Google start their foundation over a decade ago and worked with a team of engineers to look at, is search an ability to try to find signals of disease? And we built Google Flu Trends, which was an experiment that really showed that there's value in looking at big data, even aggregated and anonymized, to find signals of flu. And we certainly could track flu in the United States a couple of weeks ahead of time versus the gold standard, which relies on people going to the clinic, which is necessary, but the population-based approach is helping us think through things differently. Well, that was back when there was just search, and now there's all kinds of social networks. And I just came back from a meeting of the World Health Organization where countries across the globe are trying to figure out how do they tap into the social media within their countries, because even though we know that searching local news sources and other online material has helped us find outbreaks faster. In fact, when we started applying that approach, about half of the outbreaks around the world that the World Health Organization had to send a team to were first found out through an electronic source. So now that countries are getting better with surveillance, they're not only interested in that, they're interested in the social media because they feel like the community has signals that are in there that if we're able to figure out this data, it could really be a gold mine in trying to find signals where we don't have good public health infrastructure. For us, we think the solution is one step further, to directly engage communities. So we're putting the public in public health, so to speak, and saying that it's really great that we can look at what's referred to as your digital exhaust and maybe find these signals of disease, but why aren't we just asking people directly in a really simple format, like, did you have any of these symptoms last week? And so we've been doing this now for the last 6 or 7 years. Really, for us, it was an experiment to figure out, is it reliable to have the community directly report on symptoms of disease, and can you use that volunteer community to educate them more about flu and actually influence behavior on, like, increasing vaccine uptake? And we hope that population-based systems like this can help us answer some of the questions like vaccine efficacy that we really rely on a very bias sample to determine that every year, because almost 80% of the people with flu every year never go and see a healthcare provider. We know many of them get a flu shot, so we really don't have a very good estimate on how the vaccine really works because we're not sampling a large enough population. So again, while this is interesting in flu and helped us show that it is really reliable to have the public, these are the areas of the world that we care about, and we care about all diseases happening in these particular areas of the world. So our approach was to develop an application of bringing technology to these hotspot regions by bringing the government to the table as our #1 priority. So we don't care if the government doesn't have the technical resources or the money, but they have to have the commitment to want to really bring innovative solutions to finding and responding to outbreaks faster using technology that already exists in their country. So the idea is we bring together the developers from that country in a 3-to-1 ratio with the health experts, and we bring both the human health experts and the animal health experts together to say, what are the problems that you're trying to solve in helping find outbreaks faster? And so then I learned this working with a team of engineers and building Google Flu Trends. They're like, don't tell us what you want, just tell us the problem, and we will figure out the solution. So it's really great. The health experts meet with the developers. They tell them all their problems on the first day. On the second day, they go into the field. So because we are focused on One Health, they go to farms, they go to markets, they go to clinics, they go to hospitals, they go to the communities, and they look to see what kind of technology are they using, what kind of technology do they have access to, what is the bandwidth if we want to do mobile versus offline solutions. And then they come back and they hack away for the rest of the week, and at the end of the week, we have very promising prototypes that have been developed and co-produced between the government and the developers in their country in an open source format, and then we provide the catalytic funding to actually build the most promising tools when they look at all the different options that have come up and then help get them implemented. Another role that we're able to play as a philanthropy partner is we can bring in the private sector to help think through the partnerships that they can play in helping the government do disease surveillance, which is often very awkward for governments to make those kind of introductions with the companies. So that EpiHack photo is from Chiang Mai, and the result of that group was they created the Participatory One Health Disease Detection, or PODD. PODD is also a Thai word that means look closely and you will see. This is one of the grandmothers who is a volunteer who is trained now to use the mobile app, and the community volunteers. And the reason we decided to start this model in Thailand, because first of all, most people have 2 mobile phones. Second of all, they have a community volunteer system throughout the country where there's a volunteer to every 10 households, which is roughly 100 people. So while we were trying an experiment, could you find outbreaks faster by directly engaging the community, we wanted to start somewhere where not every element of the experiment was an experiment, if you will, that we could test out that model because the technology would work and we had a good infrastructure. So we partnered with Chiang Mai Veterinary University in really moving the model from away from the human health and let them be the lead, even though it's done with both the human health and the animal health, in partnership with the government. So the students from the university are training these village volunteers, and the academic partnership is helping the government look at thresholds and data analysis and things that, because self-reported data had never been done on such a large scale, especially between the human and the animal community, even creating common dashboards where we could look at both human and animal data at the same time is something that had never been done before. Right next door in Cambodia, where we had an EpiHack, it was a different story. The literacy rate is much, much lower than Thailand, and certainly they don't have the same kind of capacity for technology. So the end result of that EpiHack was a free hotline, the 115 hotline, and by us being able to partner with all 4 telecom companies in Cambodia, that hotline is entirely free, and it doesn't matter what phone you have or what provider you use as your mobile carrier. Then the government got really smart because they wanted to get real-time reports from the 1,000 healthcare workers who are doing disease surveillance across the country, that they tried an SMS system at one time, but even at a few pennies per message with 1,000 messages coming in, it was prohibited in cost. So after this system got built, the official reporting happens every day through the same free hotline from all 1,000 healthcare workers in public health. We also had an experience in trying this out for a mass gathering when Brazil contacted us after Flu Near You had been operating for a few years and said, have you ever thought about doing participatory surveillance at a mass gathering? So they were having the World Cup in 2014, and they contacted us in February. The World Cup was starting in June. We wanted to follow the model that it had to be developed by a local developer in Brazil, so we found this group that had never done a major project before, but they had some successful track records. And what's been great is not only did they do that for the World Cup, they also did it for the Olympics, and now they're doing it real time in Brazil using that tool. And both EpiTrack and the developers that we use in Thailand have gone on to create jobs and win awards. So even though we're doing disease surveillance, the unexpected outcome was we're creating jobs in the process. So again, looking at the hotspot map, I know you all here care about India. I don't think you have to have a magnifying glass to see India's hot red. And India is one of our priority countries in 2020. It's one of our EpiHacks that we've slated to do in 2020. We probably need to do multiple EpiHacks in India to really address all of the issues that are going on in that area. But the good news is every country that we work in, we work through regional networks. So the reason that the technology that we've done in Thailand and in Cambodia is now scaling into Vietnam and China, as well as we've replicated the model in Tanzania and now it's spreading in the region, is each of these countries belong to regional networks that we also support so that countries can not only scale innovations across borders, but have that trust-based relationship should an outbreak happen, that we can stop things even regionally if we're not successful in doing it within the place of origin. So my final slide is this is the world that we envision in applying systems change and really promoting One Health as the way we do disease surveillance across the planet. And if we're successful in doing that, we literally should be finding outbreaks in animals before we have any human cases. And when we get smart about looking at climate change and the impact on vector distribution, rainfall, and food supply for rodents and other things that can spread diseases, we may even be able to predict both human and animal outbreaks before we have any cases of disease at all. We want countries to work seamlessly across borders, not only national borders, but by working with the human, animal, and environmental ministries together to have real change. We've got other systems that we're helping build. We're crowdsourcing epidemiologists across the globe. So when those systems that are generating signals and everyone worries about false alarms, We now have a network of over 2,000 epidemiologists in 150 countries who are verifying those signals within 24 to 48 hours. And the good news is every dollar of philanthropy that we've been investing in, while our goal is to end pandemics, because we really believe within 10 years it should not be that a threat anywhere has to become a threat everywhere, we know that the money we're investing in is saving lives and protecting livelihoods every day. And so with that, I thank you for your attention and hope we can figure out a way to work with all of you, especially on the efforts we have upcoming in India. Thank you.
Great. Thank you so much, Mark.